All right, let me just inform the other participants and then we can go ahead. Just waiting for 1-2 other participants to rejoin, so then I'll go ahead. Anybody has any other questions so far? We can cover those till the other participants rejoin. I think only one participant is left. I hope they join again soon. All right, I had a private question that I have to explain superimposition. Well, superimposition is when you get a structure that you don't want to see, it is coming in the way of something that you want to see. All right, like just take any, I'll just give you one example. For example, you want to, you're searching for someone in a crowd. All right, you're looking for a family member or a friend that let's suppose you're waiting for them somewhere, anywhere, and you're looking to see if they've arrived to the spot or not. Okay, you're calling them, they're not picking up the phone, so you just try to look at them, look for them in the crowd, that have they reached the destination, whatever or not. So you are trying to look for them, but you cannot look for them very clearly because there are other people in that crowd who are maybe coming to that mall or coming to whatever area it is, but it is crowded. All right, so those other people, those are superimposing on your person of interest. All right, so they are inhibiting your view, and because of their presence, you cannot be sure that are they over here or not, are they just lost in the crowd or what. All right, so the same example you can take on and apply for your x-rays. Superimposition here means that, let's suppose we as maxillofacial surgeons, we are ordering x-rays in order to evaluate the midface and the mandible. However, there are other structures in that area as well, which won't let us examine those areas very clearly. Like the example I just gave to you guys, that you want to evaluate the anterior mandible, the problem with that is that you obviously always will get the shadow of the cervical spine on top of the anterior mandible. So evaluating the anterior mandible on any plane X-ray is almost becomes very, very difficult because of the shadow of the cervical spine. So the cervical spine is superimposed or it is in your way, and that is why you cannot appreciate the anterior mandible very clearly. All right, so that is what I mean by superimposition. All right, so we obviously you cannot take the cervical spine out of the patient, so you can view the anterior mandible very clearly. And this is the reason why in some books you will come across the recommendation that if whenever you're evaluating the anterior mandible, you should either do a periapical of that area or you should do an occlusal X-ray. All right, so that can show you some additional information that may have been masked by the cervical spine. All right, so I hope that portion is clear and that we can move on. All right. Oh, I'm sorry, I forgot about the last X-ray. This is the transpharyngeal X-ray, And the transpharyngeal X-ray was quite commonplace again before the advent of the OPG. If you look very closely at this picture, you will think that you're looking at a cutout of an OPG, but this is actually not. This is not an image that has been cropped from an OPG. This is actually your transpharyngeal X-ray. So the transpharyngeal X-ray, again, you will come across this in the centers where you don't have access to an OPG, or in the peripheries if you're working over there. So it was usually ordered for among patients with TMJ, myofascial pain dysfunction syndrome, to investigate the presence of joint disease, particularly osteoarthritis and rheumatoid arthritis, and to investigate pathological conditions affecting the condylar head, including cysts and tumors. In addition, you can also see the neck and the head of the condyle quite clearly, so you could also do it for fractures of this area, or even in cases of temporomandibular joint ankylosis. But again, since the advent of OPG, this transpharyngeal X-ray is not done routinely. So how is this done? This is the second X-ray that is done in an open mouth position, again for the same reason, to bring the condyle out of the glenoid fossa so it can be mapped accurately. So this device that you can see in this patient's mouth, this is keeping the mandible open, and it's bringing the condyle downwards. So the X-ray beam, this is basically fired through the body of the zygoma. And what this does is that obviously the condyle, which is closest to the image receptor or the X-ray film, that will be seen quite clearly on this X-ray. All right. However, you will get some superimposition from the right side condyle as well on this. So maybe it will make your interpretation a bit difficult. Okay. So what do you see in this X-ray? You will obviously see the zygoma because it is fired through it. You might see the shadow of the pterygoid plates. You can see the coronoid process, although sometimes it is usually masked by the hard palate, as well as the, it's usually blocked out by this shadow of the hard palate. You can obviously see the condylar head over here and the styloid process. You might see the soft palate shadow and this radiolucent two airways that you're able to see. So these are the two. This is the nasopharynx over here, and here you have the oropharynx, and here you will see the full continuation of the pharynx over here. I'm getting some complaints about the voice. Can everybody hear me clearly? Is my voice clear enough? Participants, please do let me know in case you're having some issues, so I'll have to repeat what I said. A bit distorted. All right. I hope it will be fine in the recordings. Anyway, if there isn't, you can always ask me what portion you did not get. However, I was just describing the anatomy, so it's nothing extra that I've mentioned that isn't already mentioned on the slides. All right, so like I was saying, you see some soft tissue anatomy over here as well, which we sometimes mistake for some pathology, but this is actually the shadow of the nasopharynx over here. You will be able to see the oropharynx shadow over here and the full pharynx over here. So this is basically the airway shadow that you will usually see superimposed on the condyle as well as the ramus of the mandible. All right. So coming back to this diagram, which I had shared with you when explaining mid-face X-rays. So the three most common X-rays are mentioned over here. That is the PA-CEPH or the PA skull, the reverse towns, as well as the panoramic. So whenever you are evaluating the anterior mandible, for anterior mandible, the PA skull is still a relatively medium X-ray, which shows you medium usefulness. However, the reverse towns is not a good X-ray for evaluating the anterior mandible, and the panoramic, again, because of the cervical spine shadow, it is only able to give you low usefulness with the context of information that it provides. When evaluating the mandibular body, the PA skull gives you medium usefulness. Reverse towns is not a good view for it at all. However, for evaluating the mandibular body, the OPG X-ray is the one which gives you the maximum amount of information. Same for the ramus of the mandible. And when you're evaluating the coronoid, in the coronoid, both OPG and PA skull are of equal usefulness. The same reason being that since these are taken in somewhat closed mouth position, the coronoid does not come downwards, hence it is obstructed by other structures such as the hard palate. So and the zygomatic arch. So you cannot see the coronoid very clearly on both X-rays. However, for the Waters view, they say that the coronoid process can give you a lot of information, that which is your OM 37-degree view. For evaluating the condylar neck, both PSF and the OPG show medium usefulness. However, the reverse Towns view gives you the maximum amount of diagnostic information. And same goes for the condylar head. And this is the reason why, for exam purposes, you will often find people telling you that whenever you are seeing a fracture of the condyle and you have an OPG, always ask for another X-ray. And which X-ray should that be? That should be the reverse Towns view. All right. So the other structures are mid-face structures. So I won't be commenting on that since we were just talking about mandibular X-rays for today. All right. Now coming to the ACR criteria for imaging of facial trauma following primary survey. So I've already explained this table to you guys, so I won't be repeating that. Let's just look at what the ACR report says regarding mandibular trauma. So this variant number 4, which they've given in their report, I've shared the report with you guys. So I hope you've given it, at least if you've not gone through the entire report, at least just have a look at the tables and what they say. So for trismus or malocclusion or gingival hemorrhage or mucosal hemorrhage, loose teeth, fractured teeth, or displaced teeth, or where you suspect mandibular injury is the cause, and for initial imaging following primary survey. So the ACR actually thinks that the CT, maxillofacial CT without IV contrast is the best appropriate X-ray. Even though it is giving you a lot more radiation, it's really about twice the radiation of radiography of the mandible, but still it is giving you a lot more information as compared to the plain X-rays. The plain X-rays or the radiography mandible, it may be appropriate and gives you maybe half the radiation dose, but still due to superimposition and a few other points which I'll discuss later on, it is not considered to be the most appropriate X-ray for evaluating the lower face. And I think I told you guys in the first session that in centers where the maxillofacial surgeon is part of the ER or the emergency room, you will find that the radiologist will do a CT scan of the entire face as compared to just the cranium and until the base of the skull. So when you already have such a complete CT, then you won't need to order any further X-rays. I have a friend who is a maxillofacial surgeon in Nepal, and he sometimes shares his cases with me just for comments and whatnot. And so whenever he sends me his mandibular fracture patient cases, I always note that he sends me a 3D CT and a full CT. So I asked him a couple of times that why are you overexposing the patient to so much radiation? Why don't you just order an OPG and other plain X-rays? So he told me that because since I'm a part of the ER team, the radiologist does a full CT of the patient, and I just take the slices that I need from that and I should share those with you. I thought that's actually quite convenient both for the patient as well as for the surgeon, because for one, you're getting all the 3-dimensional information. There is no superimposition of other structures. And the patient now does not have to get more radiation done or get exposed to more radiation, just so you can have a look at the mid-face as well as the mandible. So these are wherever if it is possible, and if you guys are part of the ER or you're working in ER, wherever you are training or currently working, So do try to tell this to your radiologist that, if you're doing the base of, if you're evaluating the cranium in emergency anyway, just bring it down all the way to the mandible or till the thoracic inlet, so you can evaluate the cervical spine and you can evaluate the whole of the face, so the patient does not have to go through enough radiation. It will hardly take them more than a few extra minutes just to evaluate all this extra region. And you can get a lot more information which you would not be able to get with plain radiography of the mandible. So let's see what this report says regarding radiography of the mandible. So in patients where you have a low clinical suspicion of injury, a patient may be ordered an OPG or a mandibular series. So you have two options over here. You can either order an OPG or you can order a mandibular series. So the mandibular series consists of a Townes or a reverse Townes, bilateral lateral oblique, meaning you have to order lateral obliques of both sides, right and left side, or true lateral view. All right. So you will have to do these 3 or 4 X-rays in order to evaluate the mandibular fractures. These have a sensitivity with an OPG. This sensitivity is about 86 to 92% for detecting simple mandibular fractures as compared to a 4-view mandibular imaging series. All right. So it means even if you're doing 4 X-rays and you're exposing the patient to 4 times the radiation dose, still 1 X-ray, that is your OPG, gives you has a lot higher sensitivity for detecting simple mandibular fractures. Specifically, an OPG demonstrated a sensitivity of 92% in detecting a mandibular fracture, in contrast with 66% with the mandibular series. So you can see there's almost a 30% difference in the sensitivities in picking up a fracture. Now, a mandibular series has several disadvantages when compared with an OPG, such as superimposition of osseous structures, difficulty in placing the film perpendicular to the fracture, and the presence of confusing spatial relationships. A mandibular series, however, does not require the patient to be upright, so which is the single biggest disadvantage of ordering an OPG, that the patient has to be able to remain upright. The patient also has to remain motionless for at least 5 to 10 seconds during an OPG, and doing a mandibular series also does not require cervical spine clearance, because for an OPG, you do need to position the head at a specific angle, so you will be rotating the neck of the patient. And if you have not excluded a cervical spine injury, then it is probably not wise to order an OPG. However, you can, even with cervical spine, sorry? Start video. Hello? Dr. Pavasha, please, I advise you to mute yourself if you're not talking to or if you're not asking questions, all right? If you're asking a question, just put it in the chat box, please, okay? Anyhow, like I was saying, even with this cervical collar, you can take a lateral oblique or the mandibular series X-rays, but that you can't do with an OPG. So, although isolated mandibular fractures have been accurately diagnosed during using radiography techniques, notable limitations include fractures of the mandibular condyle and subcondylar fractures having anterior displacement, both of which are more easily demonstrated on CT or even on OPG. So fractures which are anteriorly displaced, you cannot see those on a PA mandible or a reverse Townes view. Okay. But you can see those quite clearly on a CT as well as an OPG. In addition, an OPG can miss both non-displaced and minimally displaced anterior fractures when there is overlap with the cervical spine. So this is the downfall of all plain X-rays when compared with CT, because it's difficult to accurately eliminate the cervical spine shadow from the anterior mandible on a plain X-ray. So whenever you have a symphysis fracture, unless you open that fracture site, you cannot be sure what is actually there. And a lot of times the OPGs have actually lulled us into a false sense of security by giving us an impression that we have a very minimally displaced or a single fractured line over here. But when we opened it, there was usually a lot of comminution over there, and our treatment protocol had to change significantly. Anyhow, so a complex fracture, like I said, may be mistaken for an isolated fracture if OPG is used alone. An OPG can better visualize dental root fractures compared with CT, particularly when the fracture is located at an angle. The use of an OPG in mandibular series X-rays has now become less favorable in emergency and trauma care settings for obvious reasons. Like I said, for an OPG, you have to put the patient upright, has to remain motionless, and what if there is a cervical spine injury? So these are all things which can exclude the use of an OPG in an emergency setting. Similarly, for other X-rays, if you want to do a mandibular series, so you'll have to do 4 X-rays. That's going to take time. Other than that, its sensitivity is less. So you might miss a fracture, even though you've done 4 X-rays, you still might miss a fracture. Okay, we have a question over here. I've been asked for a plain X-ray of Stenson's duct called puff cheek view. I didn't find it anywhere. Okay, a puff cheek view is basically, I don't know which edition of Contemporary or Tucker that you have, but I believe it was the 4th edition, if I'm not wrong. Yes, in the 4th edition, you will find this puff cheek view in the chapter on salivary gland diseases. It is nothing more than a sort of a, once I tell you, you'll be laughing at yourself that what sort of an X-ray is this. But basically what you do is that you take an occlusal X-ray, all right? You take an occlusal X-ray and you put it between the teeth and the cheeks, all right? You put it between the buccal mucosa and the teeth, and then you ask the patient to inflate his or puff up his cheeks or just blow up his mouth, you know? So once they do that, what will happen is that the teeth and the parotid duct or the buccal mucosa, their air will come in between them. So, you know, the X-ray will become separated from these two. And then you can take a view of this parotid duct like that. So if you are suspecting a parotid duct stone, this is an X-ray that you can do for that. However, bear in mind, obviously, that most of the stones, salivary stones, I think over 60% are non-calcified. So even if you do a puff cheek view and you don't see anything on it, it's not does not exclude the presence of a stone. I would still recommend, instead of a puff cheek view, it's better to do a xylogram, and that is why you don't come across this X-ray in the new books or in the same book in its newer editions, because this puff cheek view has limited diagnostic relevance. All right. So if you really want to read about it, I think it's hardly given 2 or 3 lines in the 4th edition of Contemporary Oral and Maxillofacial Surgery. Yes, it's not mentioned in updated edition. So don't look for it in the new 6th and 7th editions. You'll have to look for it in the 4th edition. If you have that, you might want to look for it in the college library, or someone senior who might have this book, or otherwise just Google it. I'm sure you can find it on Google. So yeah, the puff cheek view for parotid, you'll find it there. Okay, so anyhow, moving on. All right, so that brings us to the end of session 2. So if there are any questions, I can take them now. Dear participants, any queries, any misunderstandings, or anything you feel that was not very clear? I guess if there are no questions, then inshallah, hopefully, we should have the last session on the coming weekend. Sorry, not last session, the second last session, which will be on OPG exclusively. And after that, we'll have the last session, which will be on interpretation of all these mid-face as well as mandibular X-rays. Okay, we have a question here. OPG is a combination of 2 laterals and 1 PA. Yes, it is a combination of basically 3 X-rays. 2 laterals and 1 PA view. So yes, Dr. Nohan, you are correct in that. Okay, so I guess then I will end the meeting. I will try to share the recordings hopefully by tonight, and hopefully if you still have any questions, please do share those with me in the group if you remember them anytime later, and then inshallah see you in the next session. All right. If you guys want me to include any other X-ray other than the ones that I've taught you, if you have any queries about that, please do share those with me in the group or privately, and I will try to add that X-ray to these sessions as well. All right. Okay. Thank you very much for attending, asking questions and participating. I hope, inshallah, you found the session useful, and hopefully you'll find the upcoming sessions equally useful as well. All right. Thank you very much. Take care of yourselves and see you in the next one. Allah Hafiz.